All right. Be getting this webinar started in just a moment, just giving a minute for any attendees to hop in before we get started. If you're just now coming in, welcome. We'll be starting in just a moment. Okay, all right, I see we got a few more attendees in here. I'll go ahead and get us started as people continue to shuffle in. Thank you all for joining us today for the webinar addressing underserved degenerative health issues. Today, our host, Dean, the CEO of Medical Fitness Solutions and the founder of the Lifespan Health Program, will discuss programs to address the comorbidities of aging. So during the presentation, if you have any questions and want to have Dean answer those at the end, just send those over at the Q&A feature at the bottom. We'll get those answered for you. But in the meantime, I'm going to go ahead and hand it over to Dean. He has a great presentation for you, and I'll see you at the end. It's all yours, Dean.
Thanks so much, Brittany. Today, we're going to talk a little bit about how we can potentially offer services cost effectively to an aging population, potentially outside the traditional medical delivery system. And the genesis of this thought really is over. I've spent about 40 years in the medical side of the arena, and there's a tug of war, a multi-trillion-dollar tug of war here. On the one side, you have acute care medicine and pharmaceuticals, which make $0 on healthy people. It's kind of a negative incentive to have a healthcare system that makes money on sick people. On the other end of the rope are the insurance companies and the health maintenance organizations, and to a certain extent, accountable care organizations that make money by denying treatment. So they want to minimize the treatment, even if it's needed. And the hospitals and the pharmaceutical companies report to stockholders that want, as a hospital CFO would say, more butts in bed. And we're stuck in the middle, so we need to look at how we can take care of our health more cost effectively and kind of stay out of this hierarchy of higher costs and quite frankly, lower quality of life. So we know that acute care, specialties, physician market, surgeries cost the most. And then the next step down is referral, typically from acute care into physical therapy, occupational therapy, speech language pathology, those specialties. And then on the other side of the coin, once folks are discharged from that kind of acute care arena, we think it would make sense to get them involved with exercise physiologists and nutritionists, because they're much lower costs and they can set a foundation for individuals to take care of their own health for the rest of their life. And then from there, again, lower cost of care with self-care, specially trained personal trainers, facilities that offer some of these programs and modalities to keep that quality of life and stay out of those higher cost tiers of healthcare. So we've developed a series of programs. We've traditionally worked in the third-party pay arena, but we've recently expanded out to try to scale these type of programs affordably at the technician level to a much broader audience, and again, particularly in some of these underserved communities where they may not have access to acute care and referral sources and may have difficulty getting to these facilities as well. And when we look at these comorbidities of aging, they happen typically in parallel. So we've got musculoskeletal degradation as we get older, and we have neuromuscular and neurological degradation. And as they degrade, it may seem innocuous to a certain extent, but they pile up on each other, and then we end up with serious health issues. And give you an example of that, as we look at sarcopenia or loss of muscle mass and balance challenges, and osteoporosis and loss of bone mass and balance issues and gait anomalies. Well, in and of themselves, they may not seem that harmful, but they typically can end up in an osteoporotic fracture And you probably know somebody who's had an osteoporotic fracture, especially an older person, and it's life-changing. It's life-changing and very, very expensive. And there's a big group of people who could benefit from fall and fracture reduction programming and outside traditional medicine, because it's something that we have to work on literally the rest of our life. So we've got 40 million people diagnosed with osteopenia or osteoporosis in the United States. And if you're not familiar, osteopenia and osteoporosis are typically diagnosed through something called a DEXA. And a -1 or a 1 deviation, standard deviation from healthy bone is osteopenia. -2.5 is osteoporosis. So we look at these scores, and physicians will give this diagnosis. But then we look at, well, what are the fracture risks associated with these scores? And women, it affects much more remarkably than it does men. Men have their own health issues that they win in cardiovascular and stroke and heart attack and earlier morbidity. But women, the big bane to women is osteoporosis and fall and fractures. Because if we look at the T-scores being equal between men and women, women are a much higher risk of an osteoporotic fracture. And we use something called a FRAX calculator. So we look at, age has a lot to do with it. Bone mineral density is huge. Genetics and ethnicity has something to do with it. But we're able to give a 10-year propensity for fractures by using this FRAX calculator and our T-scores. And really, it's a wake-up call for individuals that if we're not doing something to either change lifestyle or remodel bone, their fracture propensity is very high. And mentioned before, we all know a great aunt, grandmother, grandfather, someone who had an osteoporotic fracture and has experienced a downhill spiral from there. There's, additional weakness, potentially decubitus ulcers from being bedridden. You've got cardiovascular issues, so many issues that are associated with being bedridden and being inactive as a function of one of these fractures. And then we know how much they cost too. The American Association of Orthopedic Surgeons determined that it costs about $81,300 for a broken hip in the system. But interestingly enough, it costs $205,000 to try to avoid it with bisphosphonate drugs. And the reason why is that over time, bisphosphonate drugs like Fosamax and some of the others cause atypical femur fracture and necrosis of the jaw. That means the teeth don't stay embedded in the jaw. And many times an individual, they'll say that they fell and fractured their femur. It's hard to fracture a femur. It's a big bone. So when we see these atypical femur fractures, if someone will get up from a chair, the femur will fracture because of long-term use of some of these drugs, and then the person will fall. So it's actually more costly to the system to use some of these drugs to mitigate that issue. So traditionally, we've used bisphosphonate drugs, calcium supplementation, I'll get into that in a minute, weight-bearing strength training, which has some effect, and then fall reduction program. I don't like to say prevention, we can't prevent falls, but we can minimize injury with some of these interventions. And along those lines is, we work with some long-term care facilities. There's a group of about 90 of them in Indiana with whom we work. And their average resident is on 10 medications. And so some of these issues in comorbidities of aging and neurologically and musculoskeletally are affected by the preponderance of drugs that these folks are on. We never tell anybody to get off drugs. That's the physician's deal. But we can report through the client to the physician that here are some of these alternatives and maybe modifications of drugs are in order. And I get raised eyebrows every time I talk about calcium, especially when I'm presenting to a group of older women, because most of them are, if they're diagnosed with osteopenia or osteoporosis, they're either given a bisphosphonate drug and or 1,000 to 1,200 milligrams of calcium per day. And I've got a meta-analysis, 50 studies, which meta-analysis are my favorite. There's no hypothesis bias, that shows there's zero fracture risk reduction by calcium supplementation, and either through foods or through calcium tablets. And the analogy I like to give is it's like drinking a protein drink and then taking a nap. Is you won't put on muscle mass unless you use that building block of protein and then create an anabolic response with the muscles. It's the same thing with bone. If you don't compress and challenge the bone, you won't reabsorb the calcium in the trabecular bone. And then you have to process it through your gastrointestinal system. And it causes additional gastrointestinal systems and some cardiac events as well. So the risk benefit analysis is don't take additional calcium. The other kind of neat thing about remodeling bone is we create our own endogenous calcium. So when we challenge the bone, we shed bone through osteoclastic activity, and that's calcium. And then we reabsorb that calcium in the trabecular bone as we're challenging the bone. So we create our own endogenously, which we don't do when building muscle. And so this is one of our solutions. We use an osteogenic loading device. And what this does is we put an individual in an ideal biomechanical position. We have a biofeedback loop with the computer, and we encourage them to create as much isometric force safely, act in an axial fashion through the bone. And if we're able to create enough force, we know that's going to create osteoblastic activity. It's going to shed cortical bone. It's going to reabsorb that bone into the trabecular bone. And it's proven. One of the caveats is we need to have enough muscular strength with the individual to create deformation of the bone. And so in lower extremity, typically it's 4 times body weight. But most folks we work with are in their late 40s to literally early 90s. They have enough muscle mass to create that kind of tension in the bone. And if they don't, we get them involved in a strength program. So you got to have the muscular strength to do it. But if you deform the bone, you can't help it. It starts to regenerate itself. Everything we do within these systems is an adaptation. We create a stress to the body, either musculoskeletally or neurologically, and the body adapts. And this is a little depiction of what we do with these clients is we'll encourage them to exert as much force. There's no pass fail. We don't put a pre-imposed load on it. And then they get a biofeedback loop, and we keep this in a client file in 4 different positions on this particular device. And this is when we explain this to physicians and referral sources, they'll nod their head because they learned in medical school about Wolff's Law. And it's been taught for over 100 years, and deformation of the bone creates osteoblastic activity and remodeling the bone. The difficulty has been is how do you create multiple body weight compressions with 80-year-olds? Because they're not playing singles tennis or court hoops or martial arts or running. So that's when you get it as a younger person. As you get older, you need to have a modality that allows us to compress that bone in a safe fashion. And this is really cherry picking the studies. This is the best study that we've seen on osteogenic loading. So I'll temper that a little bit. But virtually every study we've done on osteogenic loading without drugs, without other interventions, has shown better bone mineralization, better DEXA scores after a certain period of time, usually 6 to 12 months, than the drug interventions or any other strength training regimen. And then, this is the discussion really to have within the big healthcare market. And I'm using best case scenario. We could move this down a little bit if it makes sense. And we could probably do a meta-analysis of the studies and really find a place to put it. But if we're able to create bone density for a 75-year-old woman of a 55-year-old woman, and that's what the study shows, then we reduce fracture propensity 6-fold. And then you start doing the math. Well, let's say it's 4-fold. Let's be a little conservative. So 4 times as many 75-year-old women have an osteoporotic fracture than 55-year-old women. Well, we can't make them younger, but we can make their bone age younger. If we do so, we're going to reduce those fractures by multiples. And if we do that, let's go back to that slide where we said it's $81,300 for a fracture, $203,000 or so trying to treat it with drugs. Well, then we have the argument both from an ethical standpoint and from a non-farm standpoint, and also from a savings to the healthcare perspective. So we have a good opportunity to discuss the financial side of this to the actuaries, as well as the efficacy side to the referral sources. And then it may seem simple, but the number one indicator of a fall is muscular weakness. So we work with programs to strengthen individuals. If you can't get out of your chair, or if you can't get off the toilet, or you can't get out of bed and walk to the restroom, you're going to fall. So cornerstone of a fall reduction program is strength training. And we do specialized strength training. We've got strength equipment in 1,000 long-term care facilities, rehab facilities, skilled nursing. We've got well over 3 million resident treatments and a proven cost of care reduction, and based upon functional independent measurement scores. So if you do strength training correctly with older people, you're going to safely create an anabolic response, increase muscle mass, increase capillary density, lower blood pressure, improve blood lipid profiles, all kinds of benefits to proper strength training in a safe environment, in addition to fall and fracture reduction. And then I throw BMIs out the window because, you know, you can get a great BMI if you smoke cigarettes and use drugs. And then BMI is misleading too from a muscle mass perspective. So this is just an example we present many times on body composition and muscle mass, but same BMI, a lot less muscle. So what we do here is, one is we can see how strong they are by the biofeedback loop on osteogenic loading, and also how much they're doing on a leg press. So we don't need to do cross sections. But we also use a medical grade 4-quadrant body composition analyzer to give some feedback to individuals as to their hydration levels, muscle mass, fat mass, etc. So we'll know how strong an individual is by objectively seeing how much weight they can move or how much force they can exert. But using a BMI to determine health on the individuals or interventions, we don't. So a big piece of fall and fracture reduction, and this has been a parlay also into a neurological discussion, is balance. So when we do a fall risk assessment, you got to look at muscular strength, you have to look at balance, you have to look at gait, you have to look at pain, you have to look at pharmacological intervention. So it's not a simple analysis, but a big part of it is what's happening from a visual, vestibular, and proprioceptive response. And that's balance. That's what's controlling our balance. So we use a device that allows us to have a malleable surface, and there's a biofeedback loop between that adjustable resistance surface. And then we can do baseline testing to see where an individual is. And then we can also let them play games. Basically, they're using their center of gravity sway as a controller, a game controller, to play some of these games. And we have various games that some are higher metabolic demand, some are lower with more acuity and control of balance. But once we see where the individual's balance is lacking, we can kind of cater a balance improvement program. And once again, this is an adaptation. We've shown you can improve balance by working on balance and progressively working on balance. So strength, bone density, balance are all things we're working on in these programs. As I mentioned, gait and then flexibility. One of the taglines of an athletic trainer buddy of mine, and I borrow it on occasion, is, you know, the quality of your movement determines the quality of your life. So we work a lot on flexibility and stretching and use some modalities for that as well. And I want to emphasize to you as I'm going through this too is, remember that chart where we showed the various caregivers and the costs associated. This program is dosed by technician level individuals. So we have created certifications for people to basically do the buttonology on these machines, because we know once a patient is diagnosed, which we don't do, and then they're discharged from whatever acute situation they have, we don't need doctorate level people pushing these buttons once we know what the diagnosis is and we know that the efficacy of these modalities. So we're able to keep the cost down low by having technician interventions on these as opposed to skilled. And the other thing is, and I'll get into it a little bit later too, is these are programs that are designed for life. So they have to be affordable that you can come once or twice a week for the rest of your life. We've got some specialty programs too. We work with now a couple of Parkinson's support groups, one here locally, one we're involved with in Scottsdale, Arizona, where we're looking at how do we quantify some of these neurological degenerative issues, and then what are the best interventions. You've probably heard of rock steady boxing. A lot of good anecdotal about that, but let's quantify, what are the outcomes, what are the stickiness of some of these things. The other thing that it may be, and we're working with a couple of long-term care providers too, is the same neurological testing and training we're doing for some of these things like mild cognitive impairment and Parkinson's. Will it be useful with long COVID and some of the brain fog and balance issues associated with post-COVID as well? And we've got a really neat tool for that. This is new. It's called a CogniView. And what it allows us to do, I'll show you the next screen, is look at cognition in 6 different domains of the brain. We've never been able to get that granular before. And again, we don't have to be physicians to look at this. We can get this, we can share it with the physician, but it has a scoring method to it that'll tell us, in essence, based upon this score, is a level of disability with this individual. So that allows us to start this individual with the right intervention. It also helps physicians look at, well, what are the pharmacological effects, and where is it affecting this individual potentially in their cognition and their acuity. So it runs them through a 10-minute test, self-administered, again, technician level. You put the person in this basically hood and you leave them alone for 10 minutes. And then we're able to get that baseline, look at what interventions we have, and then bring them back and see if we've improved or regressed. And then, what works with degenerative neurological issues? A lot of the evidence is pointing towards engagement versus distraction exercise. And I'll give you an example of that. Distraction exercise, you're on the treadmill, you're watching TV or you're reading a magazine. You're getting some cardiovascular benefit, but you're not creating additional brain-derived neurotrophic factors or BDNFs. What the Cybercycle original study showed is that engagement exercise, when you're shifting gears, when you're racing with other people, when you're steering a bike, the engagement aspect increased BDNFs remarkably over the distraction exercise. And what that has been able to show is a 23% reduction in the onset and progression of dementias. So big study that they did. So we've got interventions that are engagement exercise interventions, both with the boxing with targeted pads that we can instruct clients to hit a certain sequence, or we can ask them for a sequence and make them think about it. We're working with a company called NeuroTracker that has, think of the old time when you had cups and you had something under a cup, and you had to guess the cup. Basically, it's numbered balls 3-dimensionally that you have to follow when they're masked, and then find them again. Good combination with the balance assessment we do, where we're doing visual, vestibular, proprioceptive, acuity. So we're working on all these projects to then bring back to the baselines we have with the CogniView to see if we're moving the needle and which one's moving the needle the best. And then I don't know why nutrition and exercise have run on parallel paths for so long. And I think some of it is, fitness is so generic and supplements are so generic. But there are targeted medical nutrition and there's targeted exercises for specific health challenges. So you can boil down this big universe of fitness and nutrition and start looking at, well, what does this individual need? What's functional fitness for an 85-year-old? And what are the deficiencies? Do they have diverticulitis or other issues that they're having difficulty in absorbing nutrients? And so we paint with a broad brush. We work with a company called Mend, and they've formulated specific formulas to address some of these issues. We use one of them called Regenerate with sarcopenic individuals. because a lot of older individuals just aren't getting the nutrition they need, and they're processing it too quick. It's high on prebiotics and probiotics, branched chain amino acids, really good stuff that we know if they're having this medical targeted nutrition, we're going to get better outcomes when we challenge them in the gym. So I mentioned before is all these things you do the rest of your life. And that's why we really need to make it available in, let's say, challenged communities that don't have access or money to get to acute care and quite frankly want to stay out of acute care. We've modeled this so that we hope it can scale, especially in nonprofits or community centers or cash-based with some of the rehab providers we work with, to make it available and affordable. We'd love to have insurance start looking at it like they do with Silver Sneakers and some of the others, this being much more specialized, a little more expensive, but much less expensive than looking at that acute care cost pyramid. I want to give you a little tour of the facility here and show you what we do here. And then Brittany, if you can chortle in, how much time do I have left?
Yeah, it's at 2:30, got 30 more minutes.
30 more minutes. Okay, we're doing great. All right. Let's see if I can share this. And Brittany, if you can stay on for a minute, just tell me if you hear it.
To Lifespan Health in
Yes.
California.
Okay.
We offer evidence-based adaptive solutions for many of the challenges of aging, including loss of muscle mass, decreased bone density, balance and pain issues, diabetes, Parkinson's disease, peripheral neuropathies, mental decline, and nutritional deficiency. We utilize many FDA-recognized patented modalities to achieve optimum outcomes with minimum chance of injury. And we document your individual start points and progression with medical grade body composition, patented cognition and balance assessments, and computerized strength testing. For our clients' protection, we covalently bond our equipment with an EPA certified antimicrobial and clean with an unlisted proven to kill COVID virus cleanser. And you don't have to be elderly to partake in these proven health maintenance solutions. An ounce of prevention is worth a pound of cure. So we recommend getting an early start to living your best life. Please contact us via the website or call 760-451-9162 to find out more. We hope to hear from you soon.
Okay. Let me get back to my PowerPoint. Okay, Brittany, I don't know if there's going to be any questions here, but that's pretty much it from the formal standpoint. As I mentioned, we own and operate a couple of these centers. We certify and provide guidance and equipment for ones that want to participate in all or various aspects of this program. But Brittany, if you want to open it up, if there are any questions, I'm happy to address them.
Yeah, absolutely. Checking the Q&A chat feature. I don't see any right now, but anybody listening, if you have any questions, please feel free to send those over. Yeah, I think that was a great presentation. The video is really nice, being able to see that layout kind of visually. One question that I could go ahead and ask, you know, I know I've heard from a lot of our readers, you know, so budget is a concern, you know, post-pandemic and things of that nature. So do you have any advice as far as kind of getting buy-in, as far as say any facility wants to maybe invest in kind of trying to get some equipment like this, get some programs up and running? Do you provide any services that kind of help show, like, you know, the return on investment, maybe resources to put together to get buy-in from their leadership team?
Yeah, we have, you know, cash-based and hybrid programs. So again, we try to keep the cost down to what would be either less or equal to a copay in a healthcare environment at the lower level. So those are things that we try to do. We also work with some caregivers who set up like a hybrid system. So in the acute care side of a patient involvement. So let's say, for example, you've got a mild cognitive impairment individual and they get capitated through third-party pay. Well, you can transition them from third-party pay to a cash-based program. In, let's say, nonprofits, in WISE, JCC's community centers, I think one of the best ways to do it is try to get grant money and referrals. And hopefully that would help mitigate some of the costs. And then there's always just the cash-based program. Our programs here are cash-based. And again, we attempt and we're able to keep it inexpensive enough that people can come at least once a week. We encourage twice a week with some of these programs and work with this within this environment. Many of the things that we're doing are that do require a technician to be present, but many do not. I'll give you an example. Is with our Parkinson's program, I've got a couple clients now that will work with one-on-one once a week for an hour. And then they can come in once a week and do the strength training, circuit training we do here, and ride the cyber cycle, you know, or work on their balance program. So labor costs are mitigated. But some of this stuff can be done. Some of these programs can be done unsupervised.
Gotcha. Okay, yeah, thanks for answering that. No, that's insightful. Yeah, so let's see. Don't see any current questions, but to all attendees, so this webinar will be on demand. So we will be sharing that probably by tomorrow. We'll be sending that out. If you want to share it with anybody, rewatch it or get some notes from it. And then also Dean's contact information is here. So if you do end up having any further questions, please feel free to reach out to Dean at his email, or his phone number is there. I'm sure he's glad to help answer. Dean, did you have anything else you wanted to add before we wrap it up?
No, I appreciate the opportunity and hopefully I'll speak with some of you soon. Thanks so much. Thanks, Brittany.
All right. Thank you all. Have a great rest of your day.